Hey, this is Sandy.
And Randy.
And we're here on AT Corner.
Being an athlete trainer comes with ups and downs, and we're here to showcase it all.
Join us as we share our world in sports medicine.
Welcome back to another episode of AT Corner. For this week's episode, we have a handy dandy CEU episode.
From Randy and Sandy, I had to do that.
Man, that works. Man, that was a great way to start this bad boy.
So what are we talking about today?
We are going to talk about hand injuries. And there's no sleight of hand here.
I wish I had something to come back from that, but I don't.
Man, I didn't realize there were so many hand jokes that you can do until just now, apparently.
And we're just getting started. So this is a CEU episode. If you're interested in that, thank you so much to Clinically Pressed and Athletic Training Chat. If you are listening to this as it comes out, it is a free Category A CEU. If it is a little bit older, it is purchasable. And for National Athletic Training Month, all of our CEUs through Clinically Pressed are 25% off using code NATM25. Sweet. If you're interested, the link is down below in the show notes or the description, wherever you're listening to this.
So, for this episode, we will be talking about the anatomy relevant to hand injuries. So, of course, got to talk about the anatomy of the hand. We're going to describe some of the management of some common hand injuries, and then we're going to just kind of discuss some kind of return to play considerations for these kind of hand injuries.
I feel like hand injuries are those ones that are so important to the person who's dealing with it, but I feel like in an outside perspective, like a coach or a teammate, yes, they're like, it's just your hand.
Oh yes, I'm never gonna forget. I've had a coach before with one of my athletes having a finger injury. Hit him with, "It's just a finger."
No.
It doesn't work that way.
What do you use most often during the day?
Yes, and then let's not forget Ronnie Lott, famous Niners safety. I can't remember what the actual injury was, but cut off part of his finger so he can return to play sooner. So I think that's where it really stems from. It's just a finger.
So this evidence-based episode brings you amputation as the primary treatment option.
Maybe what not to do.
So what is the anatomy we're talking about?
Yeah, so for injuries of the hand, it's really interesting. Like a lot of the literature really focused like on the fingers. I mean, obviously there's other stuff that can go on in the hand, and then like it's also really hard because it's like hand and wrist get kind of lumped in together. Mm. And then again, same with the fingers, right? So we're really kind of focusing more on the fingers because I feel like there's more going on there that we can kind of deal with.
Like mostly the forefingers?
Yeah. We took out the thumbs for this one. So the first phalange is not in this episode. That may be a different episode, yes.
There's enough going on with that appendage.
For sure. And I think, too, like with like finger injuries, I feel like there's a lot more that we can kind of play with, and there's a lot more considerations than maybe just truly the hand itself. Because really, there's like the metacarpals, and it's like, what are you going to do, right? Like if it's a fracture, like we kind of have an idea there. So I think the fingers was kind of a nice one to kind of talk about. And with the fingers, there's a lot of tendons and ligaments that are actually around the fingers that made it very interesting. And I feel like in school, I don't feel like we really talked about it that much, about how complex the anatomy of the fingers actually are. At least from what I remember, I was just like, yeah, they're like, my favorite was like, they're like mini knees. And I'm like, oh, but there's a lot more going on than just mini knees that's happening.
Okay, but you have therapists who are literally
for this,
just for the hand.
Yeah, and that's why you have surgeons that specialize in the hand.
Right.
So yeah, no, it's true. Like there's a reason why there's a specialty because there is so much to consider and go on that I think it's important as athletic trainers to know that like it's okay if you don't feel like you're the expert on the hand and fingers, but it's good to have an idea of I may not be the expert and I might need a little assistance with this and know who to go to and how to help facilitate.
Exactly. And that's what we're here for.
For sure. So of course we're going to talk about the phalanges, right? And of course we kind of know the basic, right? That you have the proximal, middle, and distal phalanx, right? And then those bones kind of articulate to make up your proximal interphalangeal joint and then your distal interphalangeal joint.
How do you remember those? for our students. The way I remember it is the DIP.
I just know DIP and PIP.
I could never. I would always mix them up. So the DIP, how I remember it, is like if you dip your finger in water, like that's
genius.
That's the first part that's the first joint.
That's genius.
You just dip your finger.
So what do you got
dip
for the PIP?
The DIP. It's the other one.
It's the one that's not been dipped.
I've heard something really good, but I can't remember it. I just remember
that's pretty good. I just remember proximal is proximal.
Yeah, but you have to like think about that one.
No, I like that dip one. That's pretty dope. And then of course these joints are protected by collateral ligament. So this is where the idea comes in, like, oh, they're like mini knees, which in a way they kind of are. But what was also interesting is there's kind of two sections of these collateral ligaments. And again, I feel like this isn't like, I don't remember talking about this in school. So you have the kind of like what's referred to as the proper collateral ligament, which this is where anatomy always gets crazy because that's abbreviated PCL.
Oh.
Yeah.
PCL of the finger.
Yes. And this actually stabilizes more in kind of flexion, especially like kind of like the deeper flexion you go, and you'd really isolate it.
This is on both medial and lateral?
Yes.
Okay.
Yeah. And then you have the accessory collateral ligament, or your ACL in the finger.
That is so funny how that works.
Yes. And this stabilizes in extension, right? So you can kind of already start to kind of think about your evaluation of the collateral ligaments as far as, again, it's like a mini LCL, MCL kind of thing where you test valgus varus in extension and 30 degrees of flexion to kind of isolate each structure. These joints are also protected by what's referred to as the volar plate, right? So that's more on the palmar side. And literally it's like a kind of a sheet of tendon that kind of spans that joint on the palmar side. And this kind of helps protect against that hyperextension.
Which can also get irritated or in the way when a dislocation occurs.
Absolutely. And that's what it's trying to help prevent, is those dislocations.
Well, sometimes that doesn't happen.
Yeah. Sometimes it just gets in the way. In the proximal interphalangeal joint, there is what's referred to as the central slip. This kind of supports that dorsal aspect of the joint and really prevents kind of volar subluxation and dislocation as well. All right, so that's kind of giving you that kind of dorsal protection for the joint. And then in the distal interphalangeal joint, right, you have what's referred, which I thought was interesting because, again, like I feel like when you look at anatomy text or like kind of how we like talk about like the extensor tendons, like it makes it sound like, oh, the extensor tendon just runs all the way to that distal phalanx and just starts pulling on it.
Right.
But this is actually a little more complex where the extensor digitorum tendon actually, as it runs down into the actual finger, it actually like breaks off into like 3 different branches. All right, part of it comes into the central slip, and then other sections of it actually go into what's referred to as these lateral bands. And all it is like 2 bands, not like 2 bands going kind of lateral and like attaching to the distal phalanx. Like they almost attach like in a V kind of pattern.
That's where like boutonniere.
Yeah, and that's how you get those kind of formations from, like how you get like the weird swan neck, boutonniere, pseudo boutonniere, is like because of reasons like that. Because of it's not just one continuous tendon; it actually separates and kind of goes through different bands to actually get there. It was really interesting.
That is pretty cool.
Another thing that I learned from this reading, again, I learned a lot from this bad boy, is there's actually like a system called the Flexor pulley system. And basically what these are just like kind of little mini retinaculums that hold the flexor tendons basically against the phalange.
This is what climbers talk about all the time. Rock climbers.
What? I mean, yes, because this is important for this.
Right.
And we'll talk about it during the injuries, but I was like, I feel like I've never heard of this.
You have not looked at climbing injuries.
I have not.
Apparently.
Well, because I don't have a lot of climbers.
You are a climber.
But I am not doing
not
the climbs.
Someone who's been injured, not someone who's injured their flexor pulleys.
Yes, knock on wood.
Yeah.
But I'm also not doing the climbs that are really going to fire this bad boy, which we'll talk about when we talk about injuries. But essentially, they're just kind of retinaculum that kind of run from basically the MCP, and they kind of they're in different sections all the way to the DIP. And you can kind of break them down into zones. And it's basically from A1 to A5. So A1 is basically on the palmar side of the MCP joint. A2 is on the palmar side of the proximal phalanx. A3 is on the palmar side of the PIP. A4, palmar side of middle phalanx. And then A5 is that palmar side of the DIP. All right, so those are areas where the flexor pulleys are. The most common sites to kind of see injuries to the flexor pulleys tend to be A2 and A4.
So like right along those proximal, or right along those phalanx, the palmar side of the phalanx.
Exactly, yep.
Which kind of makes sense because like at the joints, it seems like it has a little bit more support.
Yeah, and there's a lot more kind of going on. Obviously, there's more motion there. Mm-hmm. Whereas over the phalanx, there's not necessarily motion. You're literally just rocking with tension.
Right.
Yeah. So now that we kind of have that kind of baseline anatomy, right now we'll kind of go into the actual pathologies of the hands. And anytime talking about hand, finger stuff, there could definitely be just countless injuries, right? Again, there's a lot of dysfunction, misformations like swan necks and stuff like that, right? And it's actually kind of interesting how like the hand and wrist, you really don't think about it, but I feel like it does make up a lot of injuries. And some reports have shown like around 25% of all sport injuries are hand and wrist.
I mean, honestly, I don't know about all sports, but I see it a lot in football.
I've been seeing it a lot because now I do have a lot more hand required sports. Mm-hmm. But over the past few years, I've seen it a lot between volleyball and basketball.
I could see basketball. I haven't seen any. I don't think I've seen any in volleyball. Maybe like one.
All my blockers, man.
Interesting. Yeah. I could see it. I just haven't really experienced that. But my stunt performers, I've had a lot of finger injuries.
Oh, interesting. I mean, I guess I see it right. Hand going to the ground and just going on people. I could see that.
Or like any other like fights.
Yeah, true.
Or if they're like passing some sort of prop back and forth to one another.
Yeah, for sure. So kind of for this episode, we're really kind of focusing on a little bit more of the common ones that I feel like are probably more common to see. Mm-hmm. First one is kind of jersey finger. This is the rupture of the flexor digitorum profundus. And this is really caused by any forced extension of a finger that's flexed, right? So the reason it's called jersey finger is like, you going up against another athlete on their jersey, right? They pull away and it forces you into that extension while you're like gripping. That's basically the mechanism. Mm-hmm. And what's actually interesting is it is divided into kind of 4 types. So a type 1 jersey finger is basically the tendon retracts to the palm.
Oh gosh.
Yeah. Normally, you don't think type 1 is usually like, oh, that's minor.
Right,
no.
You think like grade 1, but like, no.
No, type 1 is just 100 real quick.
Yeah.
And the problem with this one is the blood supply to that tendon is obviously compromised because of how much damage has been done. Mm-hmm. All right, so the tendon and the blood supply is very just kind of like delicate in this area. So when you have something that significant, right, that blood supply has been disrupted, and it could lead to is going to have a more poor prognosis. Mm-hmm. Right. Type 2, the tendon is going to retract just to the level of the PIP. What's nice about this is blood supply is still pretty intact, so it has a pretty good healing potential.
I love how we went from the palm to the PIP.
Yes. Type 3, you kind of get an avulsion fracture with this one, so the tendon actually is pulling a chunk of the bone off. What's kind of interesting about this one is it actually gets stuck at the A4 pulley, so it can't retract any further because it got stuck.
That's where the phalanx, one of the phalanxes
yes.
are?
That would be, what would we say? I think that was...
the proximal... the middle.
Yeah, that'd be the middle phalanx. So it doesn't have a chance to go much further. And then type 4, basically you get an avulsion fracture and then the tendon actually pulls away from that fracture. So it's a combination of like a type 1 and type 3.
Wow.
Yeah, that's a lot of damage that happened on that one.
Seriously. So type 1 and type 4, like, no go. Like, those are...
Yeah, those are bad news.
They're all bad news.
Yes, they're all bad news.
Those are definitely bad news.
So when you're evaluating this patient, right, you're gonna see some swelling. There's gonna be some pain. There might be some ecchymosis as well. But obviously, the biggest thing that really identifies this is just that DIP flexion just dysfunction.
Mm-hmm.
Right. So you're not really gonna see the DIP want to go into flexion because obviously there's no connection there that's pulling it anymore.
Right.
But one thing that is interesting to kind of consider is when you ask the patient, so to do this, like ideally, right, you should stabilize the middle and proximal phalanx and then ask for DIP flexion. In some cases, like in a type 3, you actually might see slight flexion. All right, so what they've kind of advocated for is add slight resistance to see how that kind of strength is, because if you add slight resistance with a type 3, you should just overcome that really easily.
Wait, what do you mean? Like, you might see some flexion.
So
like they might be able to flex it a little bit?
They might be able to flex it a little bit.
If they have an avulsion fracture, they might be able to?
Yeah. Because of how far because of where it got stuck, it still might be able to create it.
Because it gets stuck.
Yeah.
Interesting.
It still might create the motion. So that's why they advocate for slight resistance, because if you add resistance, they shouldn't be able to resist you because there's no pull on that DIP. But it's the pull on the pulley that is what was creating that.
Okay.
Yeah. So if you actually add the resistance, you'll be like way overpowering them. And then you'll know, oh, it's probably a type 3 Jersey finger.
Yeah, I guess your fingers are pretty strong.
Yeah. Yeah, so if you do see that and you see, oh, it's slightly flexed, but you're like, this is weird, add a little resistance to it.
Mm-hmm.
And if they're able to resist it, you can probably feel good it's not a Jersey finger. But if you're like, pew, probably Jersey finger. So the management of Jersey finger, it pretty much tends to be surgically managed. And a lot of stuff has advocated like surgery as soon as possible kind of thing.
Mm-hmm.
But in general, some kind of guidelines that I was noticing is like in a type 1, like this is kind of like surgery's got to be pretty quick.
So type 1 is the...
blood
the one that goes all the way to the palm.
Yes.
Yeah.
Like that has to be surgery pretty quick. But what's interesting is what I was reading is just like, within 7 to 10 days. Which I guess for like surgery, like for most cases, tends to be, I guess, pretty quick.
Mm-hmm.
But like for our athletes, it's probably going to be a lot sooner, depending on your setting.
And then the ones that I've had, I've sent and they've made them specific like splints or braces for.
Mm-hmm.
And usually they're in slight flexion.
Yes.
Because they want that tendon to be able to heal.
Yeah, for sure. For sure. In type 2, right, surgery can kind of get put off at least within 1 to 2 weeks. Type 3 is kind of the same, surgery within 1 to 2 weeks. But some things did say you could maybe get away with 3 to 6 weeks.
Well, for an avulsion fracture, I mean, I guess that makes sense a little bit. Well, I mean, fractures in the hand kind of heal within 3 weeks.
Yeah.
So that's really interesting.
Yeah.
I mean, I guess it is an avulsion fracture, but still, like...
Yeah. For sure.
Just some thoughts.
I just love how it's like, oh, well, it's stuck. It didn't go very far. We could wait a little bit. And again, that's more kind of like that get away with 3 to 6 weeks. Like some of it might be, hey, like maybe season, like at a certain point in season, the physician might be okay with it. But a lot of times that 3 to 6 weeks is more like the athlete didn't say anything and didn't think it was like a big deal. Like they may not have thought like, oh, whatever, like, oh, I jammed my finger or something like that. And then they come see you at like week 2. All right. So it's not like the end of the world. It's almost kind of like that. Yeah. You gotta love that.
Oh, the story of athletes and their fingers.
And then type 4 is again, surgery within 7 to 10 days. This is an ASAP situation.
Well, yeah.
Yeah.
If the tendon's tearing away from the fracture too.
Yeah. That's no bueno.
No thanks.
So next we have is Mallet Finger. And finally this year I broke the streak because my first, I've had 2 basketball seasons where I've had one athlete with a Mallet Finger. I had one 2 years ago, one last year. This is the first year that I didn't have a mallet finger.
What did they do? How did they get a mallet?
The ball just would hit their finger and force them into, like literally jam their finger from the ball, but force them into.
Wow.
Yeah.
Okay.
Unlucky. And this is basically just a rupture of basically where that kind of V from the extensor tendon joins the distal phalanx, right? You get that rupture.
Mm-hmm.
Now you can't extend that distal phalanx. All right, so you get just forced flexion against a contraction, and boom.
So, like, basically mallet finger and jersey finger are the opposite.
Yes. Yeah, exactly. All right, so your evaluation, it's pretty self-explanatory. You kind of just see a dropped distal phalanx, right? Like, it's kind of weird to think about it, but like we have good tension in our fingers, so you don't really see it. But if it's like ruptured, like you'll see, like it just drops. Like nothing's just holding it there, and the flexor tendons are still pulling on it.
Well, also, like, if you ask them to open their hand, like, you can see it pretty obviously.
And I was going to say, that's the next thing, right? Inability to extend that distal phalanx. So, yeah, good idea, right? To just extend. Sometimes I'll hold the middle phalanx and just ask them to extend their fingers to see, so I can actually truly just look at it to see if it moves, if it actually extends. You might see some dorsal swelling as well, and sometimes you can actually palpate where that tendon retracted to.
You know, dang, I've never thought about palpating to, like, feel the tendon.
Sometimes you can. Sometimes you can feel the bulge of where it's
I've
at.
never thought about that.
Yeah.
Now, next time I get...
That's the same with jersey finger too. Sometimes you can actually palpate like where the swelling's at. Sometimes you palpate there and you'll feel the bulge of the tendon as well.
I've never thought to do that. Interesting.
Management for this tends to be pretty conservative. You can get away with throwing them in a splint and hyperextension.
Okay. Yes, you can.
Yeah.
But if they're going to be compliant.
That is the big thing, is the compliance aspect. Right? They have to be in the splint for a minimum 6 weeks.
And like you can't take it off. Like if you take it off, you have to keep it in extension. And I think that's something that my co-head Juan does a really good job of explaining with our athletes. Like hold your finger, and then, you know, if like take the splint off, wash your hand, whatever, wash the splint, and you're holding your finger the entire time.
Yeah.
And then you put it back on, because as soon as it bends, you're basically
you could just
damaging
all that work going.
Right.
I mean, so splinting and hyperextension for those 6 to 8 weeks. Surgical consideration is one, non-compliance possibly. Or they might just be like, well, you will not be able to extend that DIP as much anymore.
Right.
Right. And what was interesting too is if there is laxity too at the PIP joint, like maybe someone who has just generalized laxity, that's how you get a swan neck deformity. I can't do a swan neck very well. Yes, you do a good swan neck. Right. So if you have laxity in that PIP and you just have a chronic mallet finger, a swan neck deformity can form, because it's almost like a compensation for not being able to do DIP extension. So yeah, that's a fun fact. But surgery might be considered also if there is an avulsion fracture that is taking up 40% or more of the articular surface of the distal phalanx.
That makes sense.
So they might, so they might be saying, hey, we need to do surgery to kind of pin stuff back. There might be some success with conservative treatment on an avulsion of 30 to 40%, right? I think that's kind of probably surgeon preference and kind of what they've seen. But yeah, that's what I've kind of heard. Like if it's just the tendon, you're pretty good with conservative. Once you start talking about avulsion fracture, surgery tends to be in the conversing.
I mean, that makes sense, especially when you're talking about fingers.
Yeah,
like,
especially when you're talking about
things
fingers.
that like you're gripping or you're moving your hands, like dominant versus non-dominant.
Yeah, for sure. And then the next one is those kind of pulley tears. And this is where we are going to talk about the climbing stuff, right? And like this was interesting for me because again, like I haven't really heard of these kind of injuries, so I think this was really kind of dope to kind of read about. I'm
so surprised still. Yeah. Like I'm so surprised. This is like all over my feed.
Oh, interesting.
Yeah.
Apparently I'm not on climbing feed. But these injuries are going to come from that like kind of that crimp grip activity, and you love the crimpy
I
climbs.
do.
I don't.
Those are my climbs. These are like
probably because they blow up my pulleys. That's probably why it's so uncomfortable for me.
They're like it's like if you think of sign language, like the letter E, like like bending in the DIP and the PIP, but extension of the
I was gonna say, but not the
MCP. Yeah.
Yeah,
That's
I hate
kind
those
of like
ones.
your crimp.
I do not like those climbs.
We call them the fingery climbs.
Yeah, I don't like the fingery climbs. But yeah, so those kind of crimp activities or grip activities are going to be the kind of mechanisms because they do put a lot of strain on the flexor pulley system. And again, this tends to be, and the literature even acknowledged, this tends to be in climbers.
Mm-hmm.
But for your traditional athletes, you'll see this in pitchers, right? Because there are some pitches that do require some kind of like kind of crimp like grip.
I could see that.
Yeah,
I could see
so
that.
you could get this in your still in your traditional sports, not just like climbers. Right? So
the problem is you're not going to get a pitcher in a finger splint.
This could be very detrimental for a pitcher.
Right. Yeah, especially if you don't have like activation of your fingers.
For sure.
You know what I noticed something like when we go climbing, if I'm not properly warmed up, and if I try like a climb that's too hard before like I warm up properly, like I can't fully extend my fingers when I'm climbing, I just can't do a full like extension of my fingers.
Yeah, interesting. Oh yeah,
And you've seen it before.
Yeah, I've seen it. Like it's legit. You're like almost in like contracture.
Exactly. Like my flexors have taken on too quickly. So I think like I'm thinking like in a pitcher.
Yeah.
Like obviously that's not from injury, that's from improper warm up. But like I'm thinking like in a pitcher, like pitchers have to be able to really control their grip.
Yeah. Yeah, for sure. You do.
So it really would change things.
Yeah. So your evaluation's fairly simple with these, right? You're gonna look for swelling. And then you could actually see a bowstring of the tendons, right? So this is basically the tendon kind of popping out. Because again, the job of the pulley is to hold this tendon in so you can actually get a mechanical advantage and actually like be able to grip and like all that stuff, right? So if that's gone, now you get like that bowstring and that tendon's going to like just pop out. So that's kind of a good sign of, hey, you probably have a pulley tear.
No thanks.
What?
No thanks.
Management for this is mostly non-surgical, and it definitely can be splinted with like a pulley ring splint. Basically just looks like a ring over basically wherever that pulley is, and it's just replacing that, right? You're basically replacing the pulley by having something that pushes the tendon back in.
That's just crazy.
Yeah. They did say you could tape it too, or you could add tape, like so add like the little tape rings, right? That can help keep that kind of tendon in as well.
It's like a weight belt, but for your finger.
Yeah, for sure. And higher grade tears of this, so tears that kind of involve multiple structures, might need surgery, but conservative tends to be pretty successful on kind of lower grade tears for these.
Did it say like how long?
Yes, we do have a little bit of timelines. All right. So, and some of that is the return to play consideration as well.
Okay. You just want to do that for everything?
Yeah.
Then okay.
Yeah. So a lot of these pathologies do have a quick return to play, even early in the recovery process, right? So it kind of depends on the sport and just how splinting can be applied, right? Like for me, like basketball, right? A lot of basketball guys don't really like, or basketball athletes, I should say, don't like a lot of things on their hands, right? It's kind of weird to shoot.
Yeah.
If your shooting hand is all taped up, splinted, you know.
I think it's also worthy to take a look at what splints you have available to you because, for example, like everyone knows the blue foam with the metal, like that's not really commonly like used in sport, you know, like, but like you could transfer to like I make orthoplast splints for fingers all the time in football, or you could use like those like little thumb caps. I have no idea what they're called, but like those little finger caps, like those are
that one's often used with like mallet finger too. Yeah, those
or you ones that we really like are called protecto splints, and they're basically just like it's a big roll, and you just cut however much you need, and it's like a little U shape, and you could put it underneath the finger, you could put it on top of the finger, you could put it on the side. I really, really like those, and I just like round the edges so they're not sharp, and then like put a little tape on them, and then just tape them on, and they're like pretty quick. Sometimes I cut them ahead of time, and then like in a game, like I could just put it on someone real quick, and then they can go in it. And those are pretty like small.
Yeah.
So depending on what sport it is, and depending on what position, or depending on what finger and what joint, like sometimes they can just go back in pretty quickly, or a quick buddy tape with extra support.
For sure. So yeah, it definitely, all those factors really determine when someone can return to play, how they're going to return to play. So like jersey finger, right? You're looking at a full return in about 10 to 12 weeks. Sooner is possible if it's a sport where hands aren't quite as important, right? So like if you're a track athlete, right, you're probably going to get back pretty quickly, right?
Maybe the baton.
Yeah.
I don't know.
You might not be on the relay, right? Or like a soccer athlete, right? That might be doable because there's not a lot of hand necessary, right?
Unless you're the goalie.
Unless you're the goalkeeper, for sure. Right? And obviously there's the risk of falling too, right? So there are ways to do it, especially if you're able to protect that splint as well. So again, you see this a lot with football. It tends to be like you can really pad something, right? And if they're in a position where they don't really need to use their hand, right, they're probably going to be able to come back a lot sooner compared to like someone who's like a receiver who's going to need his hand.
One season I had a quarterback with a pinky. He had a pinky dislocation and fracture. It was an avulsion fracture. And then in the same season, I also had an O-line with a pinky fracture. And I just took a picture of like the two of their splints together that I made, the orthoclast splints, because they were completely different. Yeah. And it was just really cool to see like they both had the same injury, like both had a pinky fracture, but the management of them and like position specific was just so different. So I'll find that and I'll post that on our Instagram. So if you're interested in that, make sure you check that out.
For sure. And really the position that they're going to be kind of splinted in, especially when they're starting to return to play, is almost like a loose fist, right? So they're not going complete fist, right? It's going to be almost like a half fist kind of thing, right? They're going to be kind of splinted in that position.
For which one?
Jersey finger.
Oh, good.
Yeah.
Like their whole hand?
Yes, it would be whole hand, I believe.
Interesting.
That was my interpretation of how I was reading it.
I haven't seen a whole hand when I send a jersey finger, but I don't know. Maybe that.
Did you see it? How did they splint it when you saw it?
Just the single.
Just finger.
Yeah.
I don't know. Yeah, when I was reading it, it said loose fist, so I just took it as like, oh, whole hand, because I guess maybe it would be hard to. I don't know.
Maybe it depends on if it's the one that goes all the way to the
maybe
palm.
Possibly. Yeah, could be. Next, again, mallet finger, right? If it's being treated conservatively, they could be a quick return to play, especially if the splinting's tolerated. And again, it depends on the sport as well. Like for one of my basketball guys, when we had him return to play, right? Like again, it's kind of weird to have the splint on the palmar side because again, if you're dribbling a ball. Right,
you can't feel it, yeah.
Yeah, and it's going to be kind of in the way compared to everything else. And so I did a dorsal splint that held him up into hyperextension. So that helped kind of make it a little more tolerable to play. But really, again, you're splinting for 6 to 8 weeks. And if compliance was great, everything went well, you can actually wean them off the splint around week 6 and use those final 2 weeks of a night splint only. So they put it on at night. And then they can take it off. Right. Again, if it's surgical, that's going to be a little more complex. And now you're probably looking at more closer to that 3-month kind of timeline. Again, I've seen that too, where, sent the kid to the doctor for the mallet finger and they wanted to do surgery with him. So I've seen that too, to where his season unfortunately was done because of a mallet finger. So again, it really depends what's going on in there, if it could be treated conservatively or not.
Dang.
Yeah. And then for your pulley tears, this one had a very just wide range of things to do, like what your kind of like timeline looked. It could be from 6 weeks to 3 months,
Oof. Yeah, try telling that to someone who needs their fingers.
And the best part is, as with most things, delaying treatment could just lead to a lot worse outcomes. Right, so again, you can kind of tape and splint in this timeline to maintain kind of that activity. And if everything is going well and there's not a lot of other structures damaged, you probably don't need surgery with this.
Mm-hmm.
So again, it really kind of depends, but that's kind of your game plan. You're looking at least 6 weeks for stuff that's pretty minor. Anything that's a little bit more major, you could start pushing that 3 months aspect. And again, a sport is going to be kind of dependent, right? Again, like a pitcher, right? This could be pretty detrimental.
Or someone who puts their entire body weight on their finger.
Exactly, right? And then, apparently, I was reading that a lot of climbers just basically tape those areas of their fingers just preventatively.
Just too, yeah.
Yeah. And they feel like it gives them more grip. Now I want to try it. Maybe I can just start doing the grip. Maybe I can start doing the fingery ones if I tape.
There you go.
I should try it. See if it does make a difference, because it does hurt my hand. I don't like it because it hurts my hand.
But you can do it.
And it's maybe my pulleys. So I'm going to try it.
Don't hurt your pulleys. It could take 6 weeks to 3 months to heal.
Yeah, but if I tape them, as classic AT, how can we tape it?
Yeah.
So nice. That's the hand.
Well, what's your action item for this?
Don't mess with the fingers, man. You never know. They're not just, it's just a finger injury. No, these could be really detrimental and can affect quality of life. But also try to work with like your physicians on what does return to play look like and how can you safely get them to return to play.
Yeah, that's a good point. Honestly, when I've sent finger or hand injuries, like a lot of times, like they'll get a splint and then like I will make a splint. So like they'll have a splint for like the day-to-day and then I'll make a splint. Yeah. And then I'll make a splint for like the sport specific portion.
For sure.
And then like we didn't even talk about rehab, but incorporating like specific rehab exercises and strengthening not just in the fingers and hand, but also the wrist and the forearm flexors and the extensors and
a lot of this stuff, because again it is going off of the tendon, and for a lot of the surgical stuff too, tendon glides were huge in this.
Glides, yeah.
And especially looking at, for a lot of the surgical stuff, it was starting right around week 3 post-op was when they were starting to do the how does it go?
Tendon glides.
There we go.
Bend straight, bend straight. Yeah.
Like that. I don't do a lot of tendon glides.
Just have to remember your thumb.
Yeah.
I always forget my thumb.
But yeah, right around week 3 post-op-ish for a lot of these in general was when they started doing that. Was starting to do the glides.
That's cool. I mean, and if you're someone is getting surgery, like you'll be able to get an idea of what the surgeon would like.
Yeah, what their parameters are, or what their protocol looks like, for sure.
Sweet. Again, if you're interested in this CEU, make sure you check out clinicallypressed.org and find our course on there. Randy, how many references did you use for this?
So this was a little bit on the lower end. I think we had probably around 8.
Okay, nice. Yeah. If you're interested in those references, they are on our website. Again, for NATM, we are doing 25% off CEUs with NATM 25. If you're listening to this as it comes out, it is free. If you are looking for more CEUs, we are still working with MedBridge. For $101 off for your subscription for a year, you can use code ATCorner. And then lastly, if you guys are new, we do every episode as either education like this, we do story episodes with stories from real life athletic trainers, or we do interview episodes where we bring on someone and we talk about something really cool for athletic trainers. So make sure you check out those other episodes. If you guys have anything else, make sure to reach out to us on our Instagram at ATCorner Podcast. And I think that's all I got.
Oh, just one more action item. I apologize. It's always a good idea to have some splints on hand.
It is.
Get it? On hand.
On hand. Man, it really took us to the end of this episode to get another pun.
Yes. All right. Well, thank you for helping us showcase athletic training behind the tape. Bye.